A very good morning, everyone. First and foremost, I would like to thank AIOS, Dr. Namrata, for giving this opportunity to speak in front of you. We will be speaking on traumatic iodialysis repair and pupilloplasty. I would also like to thank my co-instructors, Dr. Amar Agarwal, Dr. Priya, and Dr. Ashwin for agreeing to accept this instruction course, to be a part of this instruction course. As you all know that Dr. Amar and Dr. Priya, they are pioneers in this field, and they have taken this pupilloplasty and hydrodialysis repair to a global level. So now, as we all know that now cataract surgery is no more a cataract surgery, but it has become a refractive surgery also. We have various types of and that is why pupilloplasty has gained a lot of importance for the last few years. We have the SIPSers, the modified SIPSers, the MAC canals, the pupillary encirclage, and last but not the least, the SFT or the single pass four-throw pupilloplasty, which has become very popular of late, and I think it is the worldwide it is the mostly done pupilloplasty procedure. So now, before you start doing SFT, these are the things you should have on your on the operation trolley. A 9-0 or 10-0 proline suture, end opening forceps, end opening scissors, and a Lister's hook. Now, why SFT? So first thing is, it is relatively easy to do. It is not for the first 4 or 5 cases, every procedure is difficult, but as you keep on doing it, it is relatively easy to do as compared to other procedures. It is less time consuming. As you can see, you have to pass the needle through the anterior chamber only once. So you are out of the anterior chamber doing SFT within 10 to 15 minutes. It causes less inflammation again because you are passing the needle through the anterior chamber only once. And so less inflammation so all the other complications associated with inflammation are also less. And the other big advantage of this SFT is that it forms a helical self-retaining relatively flat knot. Now coming to what are the indications of SFT. So in our practice, the most common indication is cases of traumatic cataract with mydriasis. Now suppose we only do cataract in these cases, the patient will never be happy. He'll be having glare, halos, and a lot of aberrations. So it is very nice. I'll show you the videos that we do SFT in all these cases. Of late, we have been starting doing glued IOLs in all the high myopic eyes. It is because that we have seen that when we used to do glued IOLs in high myopic eyes, on the table, everything looked okay, everything looked very hunky-dory, but post-operatively, we used to see optic capture in some of our cases. So we have started doing glued IOLs in all the high myopic eyes. Then you have the Urate-Zualia syndrome. I'll come to it later, and I'll show you the video of this. Then it is a boon for patients undergoing lamellar keratoplasty for the same reason as I told you that it forms a relatively flat knot. Now, many surgeons across the world are doing it in cases of angle closure glaucoma. And now, in patients of high astigmatism, like PK patients, keratoconus patients, RK patients, it's a boon. We have done 4 or 5 cases, but Dr. Amar Agarwal is the pioneer of this procedure, and he keeps motivating us, and so he's really inspiring. And I think it would be right that he speaks on it in details and the technicalities of this procedure. Now, this is an animated video. You can see the iris defects. So, how the things. Why it's not playing? Yeah, you make a paracentesis opening. Now, you pass a 9-0 proline through the proximal end of the iris, take the other end, through a railroad, you do a railroad technique and pull it out through the paracentesis opening. Now with the help of a lister who got a MST forceps, you make a loop and bring it outwards. And now you have to pass the free end of the suture through the loop 4 times in the same direction. That is very important because only then you will get the knot. So this is the animated view. Now we see the real-time video. We have already done the glued IOL. Now supposing, that's why we have kept the anterior chamber maintainer in this. Now suppose we leave the patient like this. So you can see how the patient will have so much clear halos. The patient will be able to see the sides of the edges of the IOL. So it is very necessary that for a good vision, we do a SFT in this case. So here, as I showed you, we make a paracentesis opening, pass a 90 proline through one end of the iris, take it out to the other end. We can take it directly also or through the railroad technique with the 26 number needle, or nowadays we are also using the cannula, visco cannula to take out the needle. So once you pass the needle through both the ends, you have to be careful that you don't take the corneal fibers along with the needle. Again, through the paracentesis, you pass the lister hook, you form a loop and bring the loop outside. Now, once you have brought the loop outside, again, you pass the suture, the loose suture, through the loop 4 times. Now you may ask, why not 3 times, why not 5 times? 3 times you should not pass, because we have seen that if you pass it 3 times, many times that the knot loosens up after some time. And if you take 5 suture, then there is no difficulty, but it forms a knot-like structure and it becomes slightly difficult to slip in. So 4 is the optimal. But if you are not confident whether you have taken 3 or 4, it is better to take 1 extra. So this is a very nice feeling when you pull, both the loose end of the suture and the iris comes close together. So now the upper end of the defect is covered, and the beauty of this procedure, you can take as many sutures as you want. If you want to take 2, 3, 4 sutures, any number of sutures, you can take it, depending on the size of the pupil you want. Here, at the lower end also, we can see the edge of the IOL. So again, in the same way, passing the 90 proline through the proximal end of the iris, then to the distal end. And in the same way, with the help of a lister hook, bring the loop out, and then pass the loose end of the suture in the same direction of the loop 4 times, like, okay. 1, 2, 3, 4. And now you have to pull both the loose end of the sutures and see how nicely the opposition of the iris takes place. So now the pupil is of nice size. You can take, if you want, you can take 1 more suture also. So this is the SFT is done. Now you close the scleral flap with the fibrin glue, and the surgery is over. Now, as I told you, the optic capture cases, this is a high myopic case in which we were doing glued IOL, and there is optic capture. So you see how important it is that we do SFT. So you pass again same with the 90 proline through the proximal end to the distal end. And here I am using the visco cannula to dock in the needle. It becomes more easy than the 26 number needle. So now we have started using the visco cannula. So you take it out from the other end, and you see the IOL itself now goes inside, and you get a nice round pupil. With the help of a listers, again, you make a loop, and pass the loose end of the suture 4 times through the loop. So single pass, 4 throw. That's how the name came. So through the same direction, we are passing all the 4 passes. And here you can see the optic capture is now gone, and you continue with your glued-IOL procedure. Now, I told you what is Urate-Zwalia syndrome. So actually, the cause of Urate-Zwalia syndrome, it is idiopathic. But the patient comes with the persistently dilated pupil, which is not responded to myotics. Exact cause is not known, and the patient has raised intraocular pressure, slightly raised intraocular pressure. And when we do gonioscopy, we can see the peripheral anterior synechias. So here, in fact, SFT does do two things. You are bringing down the size of the pupil, and at the same time, what you are doing is you are pulling the iris from the periphery to the center. So you are, in fact, breaking all the synechias, and you are opening the trabecular meshwork, and thereby the intraocular pressure also decreases. Now, this is a patient who was referred to us with Urate-Zwalia syndrome, and according to the surgeon, it was an uneventful surgery done before 7 days, and so we decided to do, and the tension in this case was 34 millimeter of mercury, so we decided to do SFT in this case. It was almost 280 degrees of synechias, so I decided to do a 6-point, SFT. So from the upper end, I'm taking 190 proline, bringing out from the other end through the cannula, docking it into the cannula, and with, again, as I told you, with the Lister's hook, you form a loop, bring it outside, pass the needle or the loose end through the loop 4 times, and then you pull both the ends and see how nicely the knot slips in, and you get a small pupil. The pupil becomes small. Still, it is very large because there are many synechias. We have to bring the tensile also down. So I'll take another at the lower end. Same procedure, passing the 90 proline through the proximal end and distal end, and then with the Listers, again, taking out the loop. You can see that is why I call it a relatively simple procedure. You can do it very fast. You can come out of the eye in 10 to 15 minutes. Yeah. So again, after taking 4 passes, you pull both the loose ends, and the pupil becomes smaller in size. Now, you can make the pupil more smaller because there are a lot of synechias. So I'll take one more SFT. I'll do one more single pass 4-throw pupilloplasty so that all the synechias break. Doing it the same way, docking it in the cannula, 90 proline suture, Lister with the Listers or with the MST forceps also. Some people, surgeons, they prefer MST forceps. You bring the, loop out. You have to take precaution that you don't embed the corneal fibers, and the loop, the loose end of the suture, you pass through the loop 4 times. And then you, after this, you pull both the ends. So I think on the second or third day, the patient had very good vision. Then there were no glows and halos, and the tension from 34 came to 16 or 18, I think, millimeter of mercury. So this is the how it was done. So thank you for your attention. Thanks a lot. Now I would like to invite Dr. Priya Narang for our presentation. Dr. New.
Good morning, ladies and gentlemen. It's a pleasure to see you all here in the morning. So we begin this, we had a talk about iris repair, the single pass photo pupilloplasty and its variants, like how to go ahead with that and the description of it. So we move on to the next level now. So, well, basically whenever I consider doing an iris repair, it is always, there are two methods like. One is you reconstruct the center of the pupil, and that is a pupil-centric method. And the second is you take care of the iris-based repair. So that's an iris-based centric method. The techniques for doing both of these are quite different. So, and many times we just don't need one, we many times need a combination of both the procedures to go ahead. So every surgeon who really wants to venture into doing an iris repair should know at least one method of each, like one should be the iris repair, the pupil, and the other should be for the base repair. The basic requirements have already been highlighted. So let me move ahead with few videos that I want to show you. Now this is a case that was referred to me for surgery. Now this is a case wherein, on the left side what you see, it's an undilated image. This is how the patient looked, and post dilation, that is how the patient looked. Now what actually here is that, this patient had a history of trauma when this patient was quite young. So maybe when he was a child, and when he presented to me, he was almost 60, 65 years of age. So throughout his life, he has remained like this with a lot of photophobia inside his eye until he developed cataract. And just because he did not have cataract, nobody actually operated on him during his lifetime. So this is how he actually remained, and now when he has a substantial amount of cataract, this patient has been referred for the surgery. Because whenever you do an iris repair surgery, by and large, we need to remove the lens also along with it. So this is the clinical situation that I just told you about. And well, when we need to take this patient, so you have now to do a cataract, and you also have to do an iris repair. So what I basically tend to do in these cases is that first I would like to do a cataract surgery for this patient. So initially I would just put in a triamcinolone C because it's a traumatic case if there is any vitreous, because then again I need to prepare things accordingly. But seeing that, okay, there was no vitreous out there after triamcinolone, I just took up the iris hooks because I need to clear up the visualization for doing a cataract surgery, and I don't want that iris coming in between. So now this iris tissue is totally retracted with the iris hooks out here, and the phacoemulsification procedure is being done. And after doing the phaco and the IA, everything looks good. So then I take up a 3-piece intraocular lens. You can even use a 1-piece if you actually want. But these cases are tricky cases. So whenever I have these traumatic cases, I will always take a 3-piece IOL and put it into the capsular bag, because in case if there is vitreous and if I need to convert it into an SF IOL, I can do it immediately on table. Now, seeing this, I'm now going to do an iris repair. Now, iris repair is going to be quite difficult in this patient because this iris has been into this position for more than 50, 60 years. It has been like that. So this iris tissue is not going to behave normal. Anyway, I just start this method. I wanted to do a flange technique for this. So I have taken up a 6-0 vicryl, and I made a flange, and I have just made this groove, and from the groove with the 30 gauge needle, you go in, and I'm trying to, put this inside this, and I'm trying to retract so that, that flange can hold the iris into place. But no, it doesn't work, because this iris actually does not hold it. It's behaving differently. So this technique was not working. So then I immediately switched on to doing a non-appositional iris repair. So now here what we do actually is that, we use a double arm suture. It's an ionopolypropylene, and you pass it from the opposite end through the paracentesis incision, and you have to enter the eye with a swaying movement so that, the needle does not have any corneal fibers inside it. Now with this needle, you just see this is the second arm, which is going into that 30 gauge needle, and then we pull both the suture needles, and you can see how beautifully it slides, and then you can just titrate the tension on this, because before you tie the knot, it shouldn't be very tight, because then what will happen is that you will have correctopia at the end of the surgery. So you keep on titrating and taking up the suture, and then you can repeat it as much as you want depending upon the degree of the iridodialysis. Now when you have a correctopia, you also need to correct the correctopia also, because you cannot leave the optic of the IOL exposed, because what will actually happen is that it will again create photophobia to the patient, and we actually do not want it. So now we have to combine it with a pupil centric method, and what I'm actually doing here is, this is the single pass 4-through pupilloplasty procedure, and this is what was highlighted just in the previous presentation. It is, you imbibe the corneal fibers from the proximal and the distal end where you actually want to oppose it, and then you have that loop sliding out and then taking up the 4 throws and pulling up both the suture ends and getting that knot slide inside the eye. You do not have to do a 3-1-1 or something of that kind. You do it once with the 4 throws, it is sufficient. So that's the beauty of this technique, because things work very fast, and you can actually wind up your surgery quite fast with this surgical procedure. Although there are many other techniques which I will be showcasing them also. You can do that if you want, but we currently do this because it's super fast and super easy. The other thing that in this video, as you see, you have to be very careful of not passing the needle through the shaft iris, because now that shaft iris does not actually have any amount of strength in it, because the moment you pull both the ends, the shaft iris can give way at any point of time, and then you need to redo the surgical procedure. So that is one thing I think all the surgeons should take care of it. And as we all know, the iris tissue is quite a friable tissue. It behaves differently. If you have a traumatic cases, because most of the time, these cases are traumatic. So, and these irises, they actually are not, the same every time. So you have to be very careful with that. Going ahead with one of the other techniques is, this is the reverse 4-through pupilloplasty procedure. This is just opposite to the single pass 4-through. Being that you do not get the knot into the anterior chamber, but you get the knot behind the iris tissue. So that is it. And after the surgery, you cannot actually make out that the surgery has been done for this patient, because you don't see anything in the anterior chamber. So this is the reverse, and so we call it as a reverse 4-through pupilloplasty procedure. The difference of how we do this is that it is the way the suture needle enters and pierces the iris tissue. It is not from anterior to posterior, but you go from behind and come anterior. So that is how you pierce the iris tissue, and that is what it actually makes difference. Otherwise, the remaining procedure, it actually remains the same as you are seeing. The railroad has been done, and then again there will be withdrawal of the suture loop, and then again we will take the 4 throws and do the things. So the concept of this comes in because many times you actually do not like to see those, actually those knots are not seen, but whenever you see it on a slit lamp, you will definitely see them floating into the anterior chamber. The advantage of this technique is that it is especially beneficial in cases which might need endothelial keratoplasty in future, because having in complicated cases, if you do pupilloplasty at 2-3 places, you have those stubble of the knots into the anterior chamber. They are at least maybe about 1 millimeter or so into the anterior chamber, or maybe 0.5 or something, and whenever you unroll the graft and you do those things, manipulation, those suture knots and the ends, they do rub on the graft, and they can peel off the endothelial cells. So that is where specifically, and we have documented this into the peer review also. So this is how this technique it actually works. Now you can just see that the knot is formed, but it goes behind. It's not going to be into the anterior chamber, and this is the micro Caesars. So this is one thing which you will actually need when you do a pupil repair, because it gives you a better access into the anterior chamber, and you can see this is the anterior segment OCT scan. You do not see any knots into the anterior chamber because they are behind. So even the anterior segment OCT does not detect the suture knots into the anterior chamber. So this is what the reverse 4-through pupilloplasty is all about, and this is actually the animation which shows how this surgical procedure is done. This is for better understanding if anybody actually wants to venture into doing this. So just observe how the needle tip is entering inside. You hold it with an end opening forceps, and then you can just pierce it. The needle is puncturing the iris from the posterior to the anterior surface, and then goes in the railroad method, and then you take up the 4 throws and you do the surgical procedure. So I think with this animation, things would become very clear. The loop is being taken up, and the 4 throws are being taken, and this is how it looks like. So another animation, this will just show you the suture track, how the suture track goes around in this surgical procedure. So this is how it actually looks like. And then you take up the knot. So obviously they go behind into the onto the posterior surface of the iris tissue. Again, this animation describes the single pass and the reverse 4 throw. So this is the difference. These are some of the clinical pictures that you see. You know, the black arrow on the top left image, you actually do not see where it is. Where is the knot? So I also call it as an iris stapling because it's just like a stapler. You do it and then you don't see anything on the anterior surface, although you have a knot on the posterior side. Coming up to the single pass, I think Dr. Sameer has already covered this. So maybe I might not show this. So I can skip this. One surgical pearl, which I just took up from Dr. Agarwal for this presentation, was that, you know, this is for the benefit of all the audience. So when you're doing a pupil repair, you know, you just see this, what's going on now. You have taken up the loop outside, you have taken up the 4 throws. But yes, when you slide this, it doesn't go in. Now, at this point, please do not pull it very hard because there is an entrapment out there and this is not going to go in. But anyway, in this video, if you see that a gentle manipulation and trying to release those corneal fibers out there, it was possible to release the fibers. But always it is not the case. You do it deliberate pulling inside and you create an iatrogenic iridodialysis on table. Because on one side the iris is fixed and you are just pulling it because you want that loop to go inside, it will never go. But the point is that you have created an extra force out there. So the opposite side iris will detach and that causes an iridodialysis. And this is how you need to enter inside. What I just showed was the swiping movement of the needle. Alternatively, we also use a trocar. So I'm going to show that video also. Maybe I have a next video coming up onto that. So I'll show you how to do it with the trocar also. So, well, this is another thing which I just wanted to highlight. This was, sorry, no, this is not that. How does the knot mechanism actually work? So this is how, because you know, there's only an approximation loop in doing a single pass. There is no second knot that we are taking, but how does it retain with those 4 knots? So it's like something like a timber hitch, we call it. And even this we have documented in the Journal of Cataract and Refractive Surgery. So this is how, what you saw here, this is actually one of the methods of tying a knot. It is called as a timber hitch knot. And this was highlighted to us by Dr. Jack Holliday, that why it works, it is because of this it works. Coming up to another video, I'll just show you, you know, how we have the complications, and this was again a referred case. Now, what has actually happened in this case is that the surgeon has done a good phaco, no doubt about it. But you know what, maybe at some point of time, the iris must have got caught into the phacoemulsification probe, and now there is a big, hole into the iris out there after the phaco surgery. So now this again, as I highlighted in the previous video, you know, you cannot leave those optic edges like that. You need to close down specifically the optic edge area, if not anything else. Because these patients, they have they have good vision, but they have lot of glare in the post-operative period, and that is what they actually do not like about it. So now this case, you know, I just had to do a SFT, so maybe I was doing it under a viscoelastic. Now you can do it under viscoelastic, you can do it with fluid infusion, but what actually happens is that, you know, I would still suggest that fluid infusion is always better, because it tends to wash out whatever pigments are being released during the surgery, because iris tissue releases a lot of pigments during the surgery. So as you can see this, you know, everything looks hazy. Now that's not a corneal edema, but it is just because that the pigments have been released inside, and there is a viscoelastic, which obviously we will be removing at the end of the surgery. But it gives you a hazy view during the surgery, but then it can always be done. So it is not that viscoelastics are not good, they can always be done, but they tend to retain. So maybe you might see now again, when I have injected viscoelastic, the view has become quite good because those pigments are released. So that is one clinical point which needs to be taken into consideration. And here, you know, I'm trying to close that entire defect out there, but if you watch, Um, Again, I had closed down the defect up there, but somehow this area has opened up again. So now whether I close this or not, it doesn't matter, but I have to close this. This is very important. This is not very important. Many times we have PBIs and everything, we keep it as it is. It doesn't make much difference to the patient. So anyway, I'm doing that. I'm trying to close this, but once I do, and you can also see there is so much of chaffing. Now I deliberately need to close this. So I will go back again and I will try to close that defect which is out there. So this is how we are trying to, these are some of the clinical pearls that I'm just trying to highlight, that many times we need to choose where we actually want to do it and where we actually can skip doing it, so that we do not actually miss out where it is actually needed. So that is one thing which every surgeon should keep that in mind. You can detach the suture needle also, but many times if you feel that you can do it, if you have a suture needle attached to it, you can even use the same suture again to do the remaining parts of pupil repair procedure. So anyway, viscoelastic is being washed off, and this patient was very happy in the post-operative period, because then this is how the post-op image looked like, and things went very well for this patient. So coming up to the iridodialysis repair, we have a twofold technique wherein we combine this with the iris-based and the pupil-centric methods. Both are combined together. So this is again the iridodialysis repair. This is what I showed in the previous video, but this is the animated version, which shows you that whenever you do an iridodialysis repair, if you have too much of iris tissue into your needle, you will have a retracted pupil in that part. So in order to make that okay, you need to combine it with a pupil-centric method. Now, for us, it is a single pass 4-through or a reverse 4-through, but surgeons, they even do a modified Seepsers and McCannels and other techniques also. So this is what I'm going to show. What I showed before is that trocar-assisted repair. Now this trocar-assisted repair for iridodialysis, this is an anterior chamber trocar which is placed into its position, fluid infusion going on inside the eye. Again, a traumatic case, so always we'll put a triamcinolone out there, do a vitrectomy, clear off everything, and just check if there is any vitreous. If there is no vitreous out there, then it's good. You do a peritomy along the entire length, make a scleral groove. If you do not want to make a scleral groove, you can even create a half-man's pocket, but then you need to know where you want to actually suture so that you can create pockets in those areas. Alternatively, you can have a groove. Now this is a viscoelastic that goes, you need to flatten out this iris tissue because it is all crumpled up. So once you flatten this off, you actually know that, okay, how much iris tissue you are going to take up into the suture needle. So once you take that up, you need to come out through the scleral groove. You can use a 26 or a 30 gauge needle to do that. And the idea of getting the needle out of the scleral groove is that, you will get those knots in the scleral groove which can be easily buried into the scleral groove. So that's important. Using a trocar is not a must, but yes, it is beneficial because it prevents the entrapment of the corneal fibers, and the idea is that this trocar, it can just swivel around. So maybe you can easily cover 2 quadrants of iridodialysis, and maybe even if you have a much more, you can still swivel it around and you can introduce your needle. It's a double arm suture, and then titrate the tension and then tie the knot, and then you have to just bury it into the scleral tunnel, which I have created in this case. So you go ahead with that. Similarly, you can keep on using it. You can see it how I'm trying to swivel this and then going ahead and doing the repair in the other areas also. So having done this, I can just forward this a bit so that I can cover other videos too. So once you do that, you tie up the sutures out there, and then I'm trying to create this. This is the reverse 4-throw, and this is again how the suture needle pierces from the posterior aspect, comes up to the anterior, and then you have the suture loop coming out and the 4-throws. Many times what happens is that, in these traumatic cases, many times you might have an iris bleed also during the surgery. So maybe you might have to pause it in between for a few minutes, put in a good amount of viscoelastic, allow hemostasis to occur, and then again begin your surgery. So that's another aspect of doing an iris repair procedure, because it's a highly vascular kind of thing. And it might bleed off, especially in traumatic cases. It can bleed off any time. So this is the suture loop going in, and it goes off. So then you just take up the end opening scissors and you cut it off. You just do an AC wash, seal the conjunctiva, and you are done for this case. So I want to show you this specific case. This I just did one day before I came here. So this is again a referred case. Surgeon has operated this 1 week back, and the surgeon was doing a phacoemulsification, and he has put the intraocular lens, but yes, this is what the patient has. So there's probably an SICS was done for this patient, and this iris tissue was totally prolapsing out, and nothing is actually seen. It looks like a total iridodialysis. This seems to be a multifocal IOL. So I immediately remove the multifocal IOL because I cannot keep a multifocal IOL, because when the iris is not okay, you cannot have a multifocal IOL in the eye. So what I do instead is that I just see, and I'm happy that the posterior capsule is intact. So I just inflate the bag, I take up a 3-piece intraocular lens, and I'm just trying to put this 3-piece IOL into the bag. Even if it does not go into the bag and remains in the sulcus, it is still good enough, because these haptics are quite safe and they are not going to cause any tissue to the angle structure. So this is the 3-piece IOL that goes inside, and we just dial it into position. The trick or the main issue with this eye is how to do an iridodialysis repair. So I was quite confident I'm going to put an IOL, I know that, but I did not know that how this is going to end at the end of the day. So I'm just trying to seal this off and trying to see this. So I immediately understand now when I put a viscoelastic that okay, the iris tissue from the left side has totally detached and gone onto the right side. So that is how there is a complete hemitemporal kind of a iridodialysis, and even the superior iridodialysis. So it's a 3-quadrant iridodialysis here. So now this is going to be quite tricky. I know that. You can see I'm trying to reposit this inside. I still don't know which is the anterior side and the posterior side, but I'm just trying to place this iris tissue into its position, but it refuses, because almost like 3-quadrant it is out, and I cannot cut this iris tissue because I want to seal this eye with doing an iris repair. So then what I do is that I take up a Lester's hook and I try to manipulate, try to flatten it off. I start using the iris hooks. I'm not going to pull it too much because I know that this iris is very friable. So this is just that I'm trying to put it into place and getting the location things done. Again, the same thing, doing a peritomy, and then you can see this here. I'm not using a trocar, so I'm using a swaying movement of the needle to go inside so that there is no corneal fiber. So now here I have taken up, I just start wishing that, okay, I can do this thing properly. So I'm going ahead and, I'm doing this, taking up the peripheral iris, and, this is again a double arm suture, threading it, getting it into the groove. And I actually, honestly speaking, when I was doing this, when I did this, when I pulled both the suture ends and I could see that the iris is going back into its position, I was really happy, and that gave me a lot of confidence that, oh, okay, maybe I think I should be able to do some good job for this patient. So, well, when I get some amount of iridodialysis repair at this place, this gives me a lot of confidence, honestly. It starts looking good, actually. So you're just tying up these knots here, and then obviously I will be doing the similar thing in the area adjacent to what I did previously. So now here again, the most important thing when the iris tissue flips and goes onto the other side is to unroll it and try to get the anterior side anteriorly and the posterior side posteriorly. So that is very important. The second thing is, what you will observe is that I'm flattening the iris tissue every time I pass a suture needle. This is the most important thing, so that for doing this, because I don't want the whole iris tissue to go onto one side. So these are some clinical pearls which I'm just sharing with you because, in case if you want to do it, maybe you will be able to do it. So things start looking good. It seems to look quite normal at this point of time. And this is how, I'm able to do this. Again, the same thing for the remaining part of this. Now the trick is that is going to happen with me is that the difficult thing that will happen after doing this part is that how am I going to do the superior thing, because I have a scleral tunnel incision out there at the position where I actually want to deposit. So I know it's not going to happen at that point of time. So what I'll be planning to do that thing differently. Now what I do is that, when I have 3 quadrants very well attached, then I'm quite confident that, okay, the remaining part I can handle by doing a pupil centric. That is, I'll try to close the superior defect by doing a single pass 4th row. And I'm not going to do any more iridodialysis repair on the superior end where there's a scleral tunnel. So this is the single pass 4th row pupilloplasty procedure which is coming into effect. And this is again the 4th rows being taken. Maybe I can just forward this so that I can just fasten this up already, and I closed that, but still there is a chafing. Maximum chafing was seen in the superior part because that entire iris tissue was lying into the scleral tunnel, so it was almost like few fibers out there, and it actually did not have any strength. There is no strength in this iris tissue out there, but still I'm trying my best to do. And what I could do was that, I could reconstruct quite a bit of things in this patient. So this is how, I won't say that it's a perfectly normal pupil, but yes, it's a functional pupil. It's not the cosmetic kind of a pupil that you're going to see in this particular eye, but it has to be functional, The patient, as far as possible, this patient should be well, and I think this patient was quite well. I got a call from the hospital. This patient is quite happy with the post-op result because everything seems to be settling, the inflammation seems to be settling. So this patient is quite happy as of now. So this is the best that I could do for this patient as of today. So I think this has already been covered. So maybe, I think we have time. We have only one speaker, so maybe I'll just show one more video. So this is the modified sewing machine technique for doing an iridodialysis repair. So this is again the suture. It's a single arm threaded onto the needle. And then you have these multiple loops that they have been created, and you just pass the one end of the loop through all the loops that you have created, and then you just tie both the ends together. So then you have this sliding back into its position. Here you can do a 3-1-1 or a whatever, 3-3-3, whatever you want to do. So you just need a good knot out there, and that is how this technique actually works like. So this is the clinical case, a 26 gauge needle being threaded with the 9-0 polypropylene suture. So you just thread this and try to get just the tip of the suture at the end onto this. So this is how you go inside. It is loaded with the entire suture. This is the basic principle. Create a scleral tunnel or a pocket, whatever you are comfortable with. Along the entire length of the iridodialysis, the IOL is already into position. And so this is the modified sewing machine. We have this needle going on, imbibing the periphery of the iris tissue and going into the scleral pocket. You get this suture, you pull this suture outside. So you have this one end of the suture outside, and then what you have to actually do is you go in, catch up the peripheral part again, go in, come out, get this loop outside, hold this loop, and then again go in and pick up the area adjacent to it which you want to get it into the groove, and this is how you again come up, again pull a little bit of suture so that you have this loop, again go in and again hold that. Now when I did this technique, I was very happy that wow, beautiful, I'm doing so well. But when I edited the video, I realized one of my loop, it slipped inside. I did not even come to know during the surgery that one of my loop has gone inside. So now what I have understood is that whenever you have these multiple loops coming out, the best thing is to take up any rod or an iris spatula or something of that kind and just pass through all the loops on this side so that it does not go in. Or you have somebody holding it, but holding someone else, your assistant holding it would be quite a messy thing because you don't want any other hand to come in between. So the best thing is to take up a rod or something and then pass through these loops so that they don't go in, and then with the other hand you can keep on doing the things simultaneously. So that is how this this is the modified sewing machine. You go through the entire thing. Maybe I can run this a bit. And then the suture end, I'm just trying to pass this through all the suture loops out there. And you can just see this. At the end, you just titrate the tension and you just tie it up. So you are almost done with this. So this is how this actually looks like. If you have a correctopia at the end, then again, I'm doing a single pass 4th row pupilloplasty so that, you know, whatever correctopia is there, it can get corrected by taking up the 4th rows and doing the pupilloplasty procedure. And you can see how it beautifully, it slides inside. You cut it off with an end opening scissors, do an IA, and this is how this patient actually looks in the postoperative period. I think maybe I can close this here and pass on to Dr. Amar for this. Okay, maybe I can show this, the flange technique, one more technique. This is again a 6-0 proline suture. You create a flange, you rivet it, and again you thread it into this 30 gauge needle. It goes inside, and these flanges, they hold the iris tissue. So this is another one of the other methods of doing it. So this is an animation that it describes it. So this is how it actually works. And this is the clinical thing. Again, the iridodialysis here, and again we all make a groove which is opposite the area of the iridodialysis. You do a cataract, do an irrigation aspiration, take up, and okay, now comes this 6-0 proline. You take off the needle, you can make small pieces of proline about 6-7 centimeters, and then you take a low temp cautery, or you can even take the other forms of cautery that you have into your system, that hot point cautery, and you can even create a bulb with that. So this is how the clinical thing it actually looks like. You have this 30 gauge needle going in, and you just thread the 6-0 proline suture into the barrel of this, and this was originally described by Japanese doctors. So this is how you thread this inside. Once you get this going, you know, you create flanges on both the sides of the suture. That is the inner one, which is the riveting kind of a thing. It will hold it in place, and on the outer side, when you have it, again you will cut it and you will make a flange at that place. So you have two flanges which are holding this. So this is one flange which is holding, and then you have an outer flange also. You will make it at the, you can do it at the end. So meanwhile, you know, you take up another piece of the proline, and because you still have the other area of the iridodialysis repair to be done. And maybe you can create the outside flange at the end, because then you can just titrate the tension on the needle, on the suture, basically, so that you know how much amount of iris is being retracted at that point of time. So this is again being done. You can see this, how beautifully it actually works like. And you can just thread this off, and you get that. So these are, it's a double flange technique. We call it as a flange riveting technique. And then, you know, you can create a flange out here and then bury this into the scleral pockets. So this is how this technique works. And then you can just close this, bury this, and then you do an irrigation aspiration, and you're all set. So this patient looked very well in the postoperative period. The only important thing is you have to bury those flanges deep. Otherwise, you might have problem. The pre-op and the post-op image of this patient. Thank you so much.
Thanks a lot, Dr. Priya, for the beautiful videos. Now we have the best for the last. And Dr. Amar Agarwal, we call him the father of iridodialysis and pupilloplasty repair. And be very careful, because he is so fast, you blink your eyes and you will miss a step. So, Dr. Amar Agarwal, sir, please.
Okay. Thank you very much, Dr. Samir and Dr. Priya, for this course. So I think Priya has covered very well everything. So let's see, we can take it to the next level now, okay? I thought I'll first talk to you on pinhole pupilloplasty. So let's understand this. What is the principle here? One, we are making the pupil approximately about 1.5 millimeters. When you make it about 1.5 millimeters, what will happen is the peripheral rays of light are blocked. And when the peripheral rays of light are blocked, you'll see automatically the central rays go in and the patient gets an extended depth of focus. That means he will see distance and near without glasses. That's a big advantage. Now look at this patient, the first case I thought I'll show you. This was from the United States of America. The patient had come all the way from Philadelphia, pellucid marginal degeneration. Someone had done a tuck-in lamellar keratoplasty years back. Now the vision was counting finger 1 meter. Patient was not seeing. Now important is always check the holiday pentacam report. Now do you have this laser pointer here? So you see that 3.3 something is there. That shows the HOA of this patient. So whenever you have 0.3 is normal. So anything above 1, please take it significantly. We also just showed you the holiday pinhole device. So that's a very simple device, and I'll just show it to you in a second back again. You can see that was the pinhole device which I'll just show you the pinhole device, important for you to see because it's from Epsilon, and what basically we are doing here is this. You keep this in front of the patient's eye. So if you have a patient of keratoconus or anything like pellucid marginal degeneration, keep it in front of the patient's eye, ask him which pupil he likes. If he likes, let's say, 1, 1.5, whatever he likes, we will make the pupil of that size. So now when you have seen this holiday pinhole device, we started working on this. This patient needed a 1.5 millimeter pupil. So we are doing the single pass, 4th row pupilloplasty, just like how Dr. Priya and Samir talked to us about. Pass the straight corneal through the clear cornea, come through the side, railroad the two from the other side. I've used a 30 gauge needle, you can use a 26 gauge. Bring the loop out, that is a single pass. Pass it 4 times. Now pull on both ends, and now you see what's happening? The pupil repair has started. Now I've done on one side, now you'll do also on the other side. Now you keep on doing as many times as you want till you make that pupil small. Now look at the Purkinje image which I want you to see. That Purkinje image is extremely important. Now look, that Purkinje image is lying over the iris. So the next step what you need is a vitrectomy probe. All your phaco machines have got good vitrectomy probes available. All you need is in your left hand you got fluid, in the right hand you got your vitrectomy probe. Now I'm going to enlarge the pupil a bit so that I will make my pupil about 1.5 millimeters and I will make it bang centered on the Purkinje image P1. Remember this is P1. So there you see now I've made it round. Now let's see whether this Purkinje image is bang centered. Look at that. The P1 is bang centered, and now you know this patient should be pretty good. Once you have done this, now all you need to do is close up this case. Remember this patient has come all the way from the United States. I have only one chance to make this patient all right. I cannot ask the patient to come back to me. So let's see how the patient behaved post-operatively just now, and I'll show that to you in a second. Now you can see the patient pre-op. It was counting finger 1 meter. The HOA was 3.3. Remember the normal is 0.3. Intraoperatively, Purkinje image P1 in the center of the pupil. Post-op day 1, 6/9 and N6 without glasses. See the advantage. You can see even near without glasses. 1 week post-op, 6/9 N6 without glasses. So I thought I'll show you this case, important. The question comes, why is pinhole pupilloplasty working? We understand the broad concepts. Okay, the bigger concept is, if you take the retina has rods and cones. Now understand one thing. These rods are slender. The cones are obese. So if you see Laurel and Hardy, you know the old comic books which they showed about, the rods are like laurel, they're thin. The cones are obese or fat like Hardy. Now the point here is, why I'm making this point here is, if you take the fovea, and there are 200 times more cones in the fovea compared to the rest of the retina. Now remember one more thing. In the fovea, you do not have rods. You have only cones. I told you just now the cones are obese and fat. Think logically. How can 200 times cones fill into that small space? It cannot happen. There's only one way that can happen is if the cones are becoming thin like rods. In other words, they become very slender. That's the only way it can happen. So they are cones. They are only in the fovea you have cones, but they are shaped like rods. So what happens is the rays of the light have to hit the center of the cones to get the best effect. And that is what the advantage of the pinhole pupilloplasty is. So if you see, this is the cone. Next to it on either side, the structure which you are seeing is the Muller cells. When I have a 6 mm pupil, the rays of light will also come from the periphery and will hit the Muller cells and get refracted away. But if I have a 1 or 1.5 mm pupil, the cone is like slender like a rod. It will go straight in and go straight into the eye. So that is why the pinhole pupilloplasty anatomically is working. Once you have understood this basic principle here of the pinhole pupilloplasty, let's take it to the next level now. Now you see a patient here. Patient has had RK. Patient has got AK also been done. Astigmatic keratotomy also been done. The pupil is fixed and dilated. Now this patient is not seeing. So you have higher HOA. Look at the HOA of this patient. It's 10.9. Remember, I told you the normal is 0.3. So from now onwards, please get into the habit of checking the HOA of all your cases. Astigmatism you see is about nearly 7. Okay? But the important issue here is the HOA 10.9. Look how high it is. So now, what shall we do? We need to make this pupil about 1 mm. We check it on the holiday pinhole device. This is what Priya showed us about, where we are going from behind the iris. So this is reverse fourth row pupilloplasty. And we have to give full credit to Priya for this work done on this with single pass and reverse fourth row. So you see, I'm going now behind the iris, coming in the front. In single pass, I was going right in the front. Now from the other side also, you see, I'm catching it. Look, my needle will go behind the iris and come out. So now what will happen is the tail or the knot of the iris will go behind the iris, not in front. Where does it make a big difference? I tell you where it makes a difference is in endothelial keratoplasties. When you're doing an endothelial keratoplasty, you don't want the graft to hit the tail or the knot which is protruding anteriorly. So what you do is, if you do a reverse fourth row pupilloplasty, then it will help a lot in such cases. So here you see now, I'm going to show you the same case. Coming back to that RK patient, you can see I'm now going to do the simple way fourth row pupilloplasty. The remaining of the fourth row is just like how we show normally in the single pass fourth row. If someone is not doing fourth row pupilloplasty, please move into it. In the audience here, can you tell me, anyone tried fourth row? All of anyone? So some of you have tried. Good. So those who have not tried, please start it. Now you see, I'm going to do the fourth row on the other side. So let's look at the animation again. Take Proline needle, pass it through clear cornea, then pass it through iris. From the other side, you have a paracentesis. Remember, you need a paracentesis only on one side. Now you take a 26 or a 30 gauge needle, pass through the paracentesis, through the iris. Now railroad the two. Bring this suture out. Now look, that loop is coming out. This is single pass. Once only I've done. Now remember the number 4. Pass it 4 times. 1, 2, 3, 4. Now pull on this end and pull on the other end of that side and suture it, gets closed. That is simple. Now remember, normally you do 3, 2, 2. Every time you're going in and pulling out, you have chance of damaging the endothelium, damaging the iris, damaging the IOL. In a single pass photo is just once, but 4 times and you're through. Now see, I'm going to do some more single pass photo. What is the principle? Remember, I need to make this pupil about 1 millimeters. So if your HOA is about 5 and below, you will go to about 1.5. I'm saying roughly. If it is 5 and above, please go for a 1 millimeter. If you have the holiday pinhole device, you can get it from Epsilon. I have no financial interest in this. It's very simple. Keep it in front of the patient. Ask him which pupil he likes. By and large, they will like 1 or 1.5 millimeters. Now look, all I do is, now take my vitrectomy probe. This is important. You need a vitrectomy probe. Just make the pupil correct size, correct centered, and close up the case. Let us see how this patient behaved. Look at the patient pre-op, 2/60. Post-op, day 6. Vision is already 6/9. So you see that happiness which you see on those patients is unbelievable because the results are immediate. And that's the big advantage of pinhole pupilloplasty. So now let's move on to the next case which I thought I'll show you. Look at another case. Patient, another case came from the United States. Patient had RK, cataract, and pinhole pupilloplasty was done. From 636, vision improved to 6/9 N6 without glasses. The question comes now on the next topic, which is important, is can I see the fundus? The answer is yes. Through that same eye, this is a fundus photograph, and you can see nearly about more than 160 degrees of fundus you're seeing. So how is it possible? There are scanning laser ophthalmoscopes. You have the Mirante from Nidec, this is what I use, but you have the Optos, you have the Heidelberg, and you have the Zeiss. So you have 4 machines at present in the market which you can catch it. But let's take a theoretical example. Patient 5 years post-op develops a retinal detachment. What do I do? Okay, very simple. Take a YAG laser, shoot, make the pupil large, and you're back to square one. So now, let's look at another case which I thought I'll show you now subsequently. What is the difference between pinhole pupilloplasty and pinhole IOLs? Remember one thing. Pinhole pupilloplasty, I am changing the pinhole size depending on what the patient wants. So it is a personalized pinhole pupilloplasty. Whereas when you use a pinhole IOL, it's fixed. I cannot change it. It's fixed. Now the second problem in the pinhole IOL is the location is fixed. So if I'm operating a patient, okay, and I need to make my pinhole pupil exactly where I want the Purkinje image to, in a pinhole IOL, I cannot. It's just fixed. I just cannot change. So that's one big problem in the pinhole IOL. The third problem in the pinhole IOL is the cost. It's crazy. It's about $800. Okay? This is just a suture cost nothing. But issue is not the money here. The bigger important to me is that location and the size I cannot change. Another big advantage in pinhole pupilloplasty, because I'm bringing that pupil down, my closed angle will become an open angle. Whereas in a pinhole IOL, please remember, a closed angle remains closed angle. I cannot change it. I can change the game by YAG laser. Let's say I made it too small. Theoretical. I made it about 1 and patient needs it bigger. Just take a YAG laser and enlarge it a bit. In a pinhole IOL, again, you can't do it. So that is why, ladies and gentlemen, you see many videos of surgeons now explanting pinhole IOLs. Watch carefully. Go to the YouTube, you'll find it. Whereas in a pinhole pupilloplasty, I don't have this problem at all. All I do is, let's say it's small, I will make it a bit large. So if you make a mistake when you're doing your first case, please make it smaller. I can always enlarge it. If you make it 4 millimeters by mistake, then I have to reoperate. Because if the patient needs a 1 or 1.5, I have to reoperate and make it smaller. So look at this patient of keratoconus again. Pre-op, post-op, and look at the fundus picture below. Through that 1 millimeter or 1.5 millimeter pupil. Now look at this picture. This patient came to me from Bangladesh. Slash wound, knife injury, cut. The surgeon in Bangladesh had operated the patient. The vision was just 660. Cataract is there, obviously there. Then I was going to operate the patient. I asked him, what is the HOA of this patient? Now this told me the HOA is about, look at that, 40 astigmatism. Can you believe it? And the HOA was 109. I said, hello, what are you guys talking? 109? Normal is 0.3. I've never seen a case of 109. This is crazy. Can you imagine how badly aberrated that cornea is? If a 0.3 HOA has become 109 HOA, you can think how badly aberrated that cornea is. So now, I started operating this case. Now I said, listen, the suturing is bad, so let me open up the sutures. So I opened up the sutures first, okay? Now I know there's a cataract there, and this is the big mistake I did. I first opened up the sutures. Now I started my rhexis, and I'm going to do my phaco here. So you see now, once I've done my rhexis, I'm doing my hydrodissection. Now I go in for my phaco, and you will see the fastest phaco in the world, because watch what happens. I've just gone. Look on slow motion. Oh, you see that? My whole wound opened. What does it tell you? I should stop operating. You see, I should have not removed the sutures. I could have done that suturing of the cornea after the phaco surgery. But like stupidly, I did that before, and now the whole wound has opened up. So now my whole cataract came out, nucleus came out through the wound. Now anyway, once it's done, I now have to resuture the entire cornea back again. I was going to anyway suture it, no doubt about it. But I should have done that after the phaco, not before. Still is leaking. Still is leaking. So I have to put some more sutures. Once I put in some more sutures, I will then go in and do the IOL implantation. So here you can see I'm putting a 3-piece IOL. I always put 3-piece IOL in such cases. I tell you why. If I get into a trouble and I get a PC or something happens in the middle, in this case there's no PC rupture. But if it happens, what will happen is I can anyway do a glued IOL. So now let's move on to this case some more. So here you see now I'm going to do pupilloplasty. Normally, ladies and gentlemen, anyone will tell you let's do PK in this case. So the process is like this. You have a case like this, there's suture. Then 2-3 months later, they'll do the cataract or IOL or whatever it is. Then again 3 months later or 6 months later, they'll do a penetrating keratoplasty. The new concept which I'm talking to everyone is, can we avoid a penetrating keratoplasty in such cases by doing a pinhole pupilloplasty? So let's see whether we can do it or not in this case. Now remember, this patient is from Bangladesh, okay? This patient cannot come back. There are visa issues, there are hotel issues, there is monetary issues also for the patient to fly back in. So I have to make this patient all right. It's a young patient, okay? So next step, keep on doing the pupilloplasty. The advantage in the photro is you can do as many times as you want, okay? It's very simple. Once I have done this, then I will take my vitrectomy probe. Now look, I'm taking my vitrectomy probe, clearing a little bit of that hyphema which is present, checking that pupil. I'm going to miss that scar a little bit, just a little bit, so that enough for the pupil to go through. And look at that. That's what I've created there. My Purkinje image should be bang on track there. Now question comes, how did this patient behave? So let's see how this patient behaved. Post-op day 1, 6/12. Look at this patient. Pre-op, post-op day 1, post-op day 3, 6/6 and N8. As I said, the advantage in this, you have extended depth of focus. But look at the HOA. From 109, it has become to 5.2. The astigmatism from about 40 became 10. But please understand, that is because I resutured. Actually, the beauty of the pinhole pupilloplasty is, whatever the HOA is pre and whatever the HOA is post is the same. The astigmatism, I have not changed anything. But what we have done is, we have neutralized it. So, advantage here is, let's say a patient comes to me with 10 diopters, I don't mind. If he's 20, again I don't mind. Because for me, it does not matter. Whatever his astigmatism is, we will anyway neutralize it. We have not changed his astigmatism. We have not changed his HOA. They remain the same pre and post. So this is what I thought I'll first talk to you on, is this thing called pinhole pupilloplasty. I talked to you another topic, because this is important for us to see. Now imagine you get a patient like this. Patient is a pellucid marginal degeneration, and you get cases like this. Now you know what, many people, they'll do a peripheral cut, suture it all, it's a total mess. important, why am I showing you this? Look at preoperatively, the Purkinje image is decentered already, preoperatively. When the patient is lying on the table for me, the Purkinje image is already decentered. So when I'm seeing this particular holiday pentacam, I'm seeing that thing, and I'm seeing, look at the Purkinje image is quite decentered. The inverted one is P4, don't look at it. One thing remember, these patients, we will make pseudophakic, because one, it neutralizes the spherical aberration, power, whichever it is becomes 0. Second thing is, I don't want this patient to come to me with a cataract. Third thing is, the astigmatism I will anyway neutralize with the pinhole. So once I have done this, I'll then put my IOL inside. Then I start working on the pupilloplasty. Why am I showing this particular case is to show you I am going to decenter the pinhole a little bit to match my Purkinje image, which is already decentered. If I don't do that slight decentration of the Purkinje image, and I still say, no, I'll stick to the bank center, that patient is not going to be happy. And that is why I'm showing you this case of pellucid marginal degeneration, in which I'm decentering the Purkinje, the pinhole pupil to match my Purkinje image. So you see, I'm going to do some more of this pupilloplasty. You see, I did a vertical, and now I'm doing a horizontal. So depending on the situation, you can do a vertical or a horizontal fourth row pupilloplasty. Once you have done that, I will make it slightly smaller and smaller until it is slightly better off, and I can make my pupil approximately 1 to 1.5 millimeters. Look, it's now approximately, my rough calculation will be about 3. So I need to make it a bit smaller. First you make it smaller. When it becomes too small, you can always take a vitrectomy probe and make it correct. So here you see again, left hand has the fluid inside the eye, right hand has my vitrectomy probe. Now I will make it bank centered. I use the Constellation machine, but you can use any machine of your choice for the vitrectomy to solve this case. Again, now look how nice the patient is looking on table. Let's see how the patient looked post-operatively, and we'll soon realize the pupil is decentered to match the P1 image as I told you about. Close up this case now. See how the patient behaved post-operatively. So this is a case of pellucid marginal degeneration, which I thought I'll show you because it was important for us to analyze and see this particular case. So look at this, post-op day 1. Vision is already 6/9. And that was the HOA of this patient, 3.1. Now I thought I'll show you one more thing, which was very tough case which came to me here, and I'll show you just now. This patient, look what has happened. This patient had had a intact done. Now look at that. The patient has scarring. There is corneal vascularization, high astigmatism. The HOA is about 4.5. Now normally, I've got an opacity. So now what do? Do I take out the intacts? Do I do a penetrating keratoplasty? What do I do? If I do a PK, that vascularization will definitely make me reject. I said, listen, leave the intact as it is. Don't touch the corneal opacity. Now what am I going to do? Vision is 6/60. You can see the astigmatism is quite high. You can see the HOA is about 4.5 nearly. So what I'm going to do is I'm going to do the phaco obviously because the patient has definite cataract, and we will make a pinhole pupil. So in other words, I am not going to remove the intacts. I'm leaving them as it is. The corneal opacity is there, does not bother me one bit. Okay, the corneal vascularization is there, does not bother me one bit. All I do is now shift to the fourth row pupiloplasty. In other words, I'm going to do the pinhole pupiloplasty. Let's see how this patient behaved now at the end of the day. So here you see, pass through clear cornea one side. From the other side, you have this railroad, the system through the 26 or a 30 gauge needle. I tend to use a 30 gauge needle because it's smaller, but it's sometimes difficult to railroad it. So if you're comfortable with the 26, that's also fair enough. But the principle is simple. Use the fourth row pupiloplasty. If you tend to do a cerclage, one, it takes 45 minutes. I'm telling you honestly. Okay? Second thing, when you do a cerclage, you cannot use a vitrectomy probe to correct the pupil the way you want it. This patient was blind as a bat, 660 vision, and you should see the patient the first post-op day. These patients will fall at your feet. One is a simple procedure. You have patients post-PK, pseudo-faking. They don't see. How do you know how much astigmatism you're going to create in them? All of these patients will become absolutely 20/20 vision with N6 vision or J1 vision. So you see, I'm making it smaller and smaller. The advantage in the fourth row is it's a very simple procedure. Anyone can do it. So if you are just moving on to iris repair, first you move on to this technique of fourth row pupilloplasty, and the same life becoming very, very easy for you. Here you can see I made that pupil a bit slightly slit-like. It will become slit-like because when you're keeping on doing 1, 1, 1 on either side, then you take the vitrectomy probe and then you make the pupil exactly round and effective the way you want it to be. So you see some more iris repair is being done, and look at the Purkinje image, it's falling on the iris now. Once it's fallen on the iris, now I will take my vitrectomy probe and correct it. Here you can see now, taking it there, using the vitrectomy probe, enlarging the pupil exactly, making it the right size. Approximately 4.5 HUA, I expect to create a 1.5 millimeter pupil. But best is to use the holiday pinhole device, a very simple device which you can easily get in the from Epsilon available here. So you can see once I made that pupil the right size with the vitrectomy probe, as you can see me doing that. Now let's see how the patient behaved post-operatively. I can also switch off the light from outside. I'm using an endometer to see better, as you can see here. Once I made the pupil round and correct size, check whether the location is also on track, and look here, microscopic light is switched off, and you can see the pupil bang centered. Now let's see how the patient behaved post-operatively. Let's see that just now in a second. So here you can see, this the idea is to show you we have moved on to pinhole pupilloplasty not only for astigmatism or high HOA, also for corneal opacities, for corneal scarring, things like that, where things will make a huge difference to these patients. So look at this patient now here. Pre-op 660, you can see how it's looking, Purkinje image bang centered, and post-op day 1, vision has come to 6, 9. Now I thought I'll show you another new technique which we just started, and we also got it published. This is called the tri-fold technique. I'll just show it to you in a second just now. So now problem is this, in this technique. What happens if you have a large iris defect like this? When you have a large iris defect like this, about let's say 120 degrees or more, if you try to do the fourth row pupilloplasty, it will just tear. You cannot close it. Then you are going to go to artificial iris or something like that. Look at this. Patient has large iris defect. I'm trying to repair it with fourth row pupilloplasty. See what will happen now. When I try to repair it, and I'm going to suture it, see what's happening on the other side. Iridalysis is forming. So to solve this problem, we suddenly thought of doing a technique called the trifold. As Priya talked to you, we use for iridalysis the trocar-assisted iridalysis repair. Now what we do in this trifold is, we are using the same principle. So let's look at the animation first, then we show the surgery. Take a 25 gauge trocar, fix it on one side. Now you take a double arm Prolene needle, pass it from the trocar through the pillar of the iris. Now the same double arm through the other side. Now all you have to do is pull. When you pull, you see what happened? The iris pillar has got closer. Now I've taken out this trocar, fixed the trocar on the other side. Now the same principle. Now look what's happening. The two pillars have become closer to each other. Once they become closer to each other, so this is a threefold technique or a trifold technique. We did one, we did a second, now we'll do the fourth row pupilloplasty because now the two pillars are much closer and you'll be able to suture up this closer. So this is called the trifold technique. Here you can see me now bringing this loop out, doing the fourth rows. Once you have done the fourth rows, I pull, case gets completed. So this particular case, as you can see here, had been operated, sent to me with the complication of large thing. I fixed a glued IOL. Now the question comes, how do I repair this iris? So as I showed you, these are from Alcon. You can get these trocars from Alcon. Okay, I use them for a trocar AC maintenance to have fluid in the eye also. But the same trocar, see it's blue coloration. If it's blue, it's 25 gauge. So I pass it through one side. Once it's inside that eye, the advantage with this trocar is when you're passing the double armed, you'll not lock onto the corneal tissue. So here you see, once I've passed it there, I'm catching this iris there, passing that same needle through that iris. Now from there, it'll come out through the sclera. So this is the first arm. Remember that. Then, once you have railroaded these two, you can see I've taken a 30 gauge from the other side. I'll railroad the two, bring it out. Now I'll pass the second arm also and do the same thing on the other side. And all you do is pull. Once you have pulled it, you will see that iris pillar coming closer to its partner on the other side. And that is the game plan. Once that defect, which is large, has become smaller, you'll see life has become much easier for us to do the pupilloplasty. So you can see now, see how close it's become now. Now I suture up this. Now remove that trocar. I'm fixing the trocar on the other side now. Once that's done, you see again, same double arm. You need a double arm Prolene needle. Now look what's happening. You'll see subsequently, in this case, these two pillars have become closer. Now see the distance between the first surgery when we started, and now you compare it to the one you have ended it with. Now, ladies and gentlemen, it becomes obviously clear, once the distance has become smaller, I can easily do a pupilloplasty. Otherwise, I tell you what, you'll have to have a big problem. This patient will have glare, photophobia and all, or you'll have to fix an artificial iris, things like that. And you can see here, we have done the pupilloplasty and closing up this case. So basically, when you're doing the trifold, remember, trocar assisted iris on one side, trocar on the other side, and the third trifold is the pupilloplasty being done. So here you can see, I'm doing the pupilloplasty, closing it down as many times as you want. Now, if it has become too small, always use your vitrectomy probe to enlarge that pinhole pupil. So you can do some more of this pupilloplasty to close the peripheral defects also. Call it is yours. It's all in your hand. I've got fluid continuously going on inside the eye. As you can see, the trocar AC maintainer gives me fluid also continuously inside the eye. Once this is done, now I will take my vitrectomy probe and check whether my pupil is right on track or not. And you see me doing that just now. You can see that Purkinje image. Again, concentrate on the Purkinje image. See how it is looking. See that I enlarge the pupil enough to get a good enough pupil. Purkinje image bang centered. The other one is inverted, is P4. Remember that. There are 4 Purkinje images. We have P1, which you're seeing, P2, P3, P4. P2 you don't see. You see P3, which will be too large. By and large, you will get confused between P1 and P4. Remember, P4 will be inverted. That's all. Once that's done, I've closed up this case and sealed it down. And you can see how the patient looks at the end of the day. I think we have just few minutes left only. So rather than me talking on any more videos here, I thought I'll first show you now, talk anything to summarize, and we can have question answers for the few minutes left. So by and large, in this course, what have we done? We've tried to show you various techniques. We showed you the pupilloplasty, we showed you the sewing machine, but to be honest, we used the trocar assisted iridiolysis. We showed you the two-fold technique, that is combining the iridiolysis with the photro. Remember, when you do an iridiolysis, you fix the iridiolysis, but the pupil will be decentered. So you want to make that pupil back on track, you have to combine the trocar assisted iridiolysis with the pupilloplasty. We talked to the pinhole pupilloplasty. We showed you how it can handle also corneal scarring, corneal opacities, things like that. And also at the end, we talked on the trifold technique. I'd like to thank Priya, Samir, and all of you for coming early morning for this course. Any questions, please feel free to ask. Yes, please, sir.
I think there were wonderful videos that you showed. I just have one question. In case you need to dilate the pupil, you talked about doing laser for those sutures. So does the suture actually fall into the anterior chamber, and then what happens? I mean, have you had an experience with that?
So what happened is in 2017 JCRS, we published a paper on pupil dilatation after fourth row pupiloplasty. See, you have done pupiloplasty here. You have not done here and here, so it does dilate. So the 1.5, let's say 2 to 3 millimeter pupil will become 4. I'm not saying become 12. It's pretty good enough. When you go to a pinhole pupil, my point was, suppose he gets a retinal detachment. Even through 1.5, I can see 168 degrees fundus, so it's not issue. Shoot the iris. All you do is shoot the iris, and you enlarge the pupil. When you shot the pupil, iris, you get a large pupil anyway.
Thank you. I have another question from Priya. The case of SICS that you showed where you used multiple sutures. So were you using multiple proline sutures for each throw that you took? Were you taking...
You mean you are asking me about the scleral tunnel incision?
Yes.
That was a 10-0 suture.
That was a 10-0 proline,
Yeah, that
is
was
it?
a 10-0 proline suture.
Okay.
Yes.
Thank you.
Any questions?
Yeah, we are open to questions, please.
Sir, I've never done a fourth row pupilloplasty. How do I start?
Very good question. Very important, I like that question. So how do you start? Very simple. Take a simple case, clear cornea. Take a Proline's needle. I'm telling you frankly, it's very simple. I've got my videos on YouTube. Priya's videos are on YouTube, all of us. So all you do is, I'll talk from there. I'll tell you frankly, it's the easiest technique you can think of learning. You don't do glue dial, I don't mind, but learn this technique. It'll change your life. So you need a glue dial forceps. Take an end opening forceps. You will have them dime a dozen from any company you will get. Right now, Epsilon, or I don't know, Esicos, all of them have it. Pass through the clear cornea. You can do a horizontal, which is easier. Let's take horizontal if you're doing. Pass through clear cornea. Now the iris is there. Catch the iris. Pass it through the iris. Leave it like that. But remember, your eye should be pseudophakic.
Okay.
You will hit the cataract. So if the patient is phakic, make him pseudophakic.
Okay, sir.
Now you leave it there. So the needle is touching the IOL. Correct, no?
Yes, sir.
Agreed? Now you made a paracentesis on one side. Now take a 26 gauge needle. Do like this side so that you're not entering into the cornea, entering into paracentesis. Catch, pass it through the iris. Okay?
Yes.
So you got now needle on one side and the Proline needle on this side. Make them touch. It will Proline needle go into the 26 gauge needle, correct?
Yes, sir.
Pull out the 26 gauge needle. This Proline needle will come out with it. Yes, anybody having any doubts till now? No. Sure? Have doubt, please stop me. I'm here for all of you. Understand?
Yes,
pulled it out. So now what has happened? You got a suture which has come out like this.
Yes, sir.
Correct? All you do is now bring a loop out. You have a dialer, you have a chopper. Simple. Take the dialer and chopper and make a loop so that the loop comes to the center of the pupil.
Okay.
Now go into the same end opening forceps.
Okay.
You don't have to spend money on any equipment. Same end opening forceps, catch the loop, bring him out through the paracentesis.
Okay,
Correct?
sir. Yes.
So what did? I got a loop out, suture out. Now I brought one loop out.
Yes, sir.
Correct? There's one needle there, no? Cut it. Because you don't want to put it 4 times the needle. That small suture, 1, 2, 3, 4. Same direction. You can't do 1, 2 and then do reverse. You go back to 0 only.
Okay.
Do 4 times. Correct?
Yes, sir.
Any doubts till now, anybody? Sure? Now you got suture here, no? Pull, game over.
I have a suggestion that, doing it before you do in a human eye, because this is not as simple as it looks in the animation and things. Because there is also, when you are venturing into doing this, it is also the direction of the needle. Otherwise, it keeps on swiveling like this. I would advise to take up a wet lab course for learning the
I've already enrolled.
pupilloplasty. Or, yeah.
I've enrolled, sir.
And
here,
alternate.
in
See,
SST. Yes.
in that, I would suggest just focus on the movement of the needle. how you are manipulating it into the anterior chamber, because then it will be a human eye when you will be doing it. And believe me, if you do not hold that long needle properly, you know, it keeps on swiveling like this, and you might even hit the corneal endothelium, or you might hit the lens or something out there. So these are finer points which you will only learn when you do it
When we
yourself.
practice.
So I think a wet lab course would serve very well. And even if you are not in a wet lab, I would suggest, you know, get an animal
It's
eye
only
or something
practice,
of
I
that,
think.
and you
Practice
have
and
to
practice.
practice.
And I'll tell
Initial.
you one thing, it's not difficult, trust me, all of
And it's not difficult, yes.
especially if you have patients with high astigmatism and things like that, it makes life very easy.
Thank you so much, sir. Thank you, ma'am.
Thank you.
Thank you
for
so much.
being here.
Thank you, everyone.
One question, please.
Okay.
Do you use straight needle or curved needle?
It's a straight needle.
Straight needle.
Straight 90.
Curved is available, but it's not here.
But do you bend it or not?
No, we don't make it. It's straight.
Thank you.
Yeah. You will need probably a curved needle if you are doing the cerclage. For that, you need a curved needle. That is very beneficial for doing a cerclage. But otherwise, you can use a straight needle.
Okay. Thank you.
So we end the course. Thanks a lot, everyone, for coming and making this course worthwhile. Thanks a lot. Thank you very much.